Hello and welcome to this session on clinical debates and consensus recommendations on the use of anti-angiogenic agents in lung cancer with a focus on the elderly patient. My name is Dr. Mark Sosinski and I'm the Executive Medical Director at the Florida Hospital Cancer Institute. The major question that we'll be addressing today is there a role for VEGF inhibitors in advanced non-small cell lung cancer in the elderlies? And what do the experts think? Well, back in November of 2015, a panel of 6 experts was convened to really discuss and debate critical issues on the use of anti-angiogenic agents in elderly patients. And the purpose of this think tank was to identify a consensus recommendation from this expert panel. A slide presentation was created summarizing these consensus recommendations. And various talks were given to community oncologists, and there was a comparison of responses between the expert panels and those learners who attended the live meeting. And obviously there were some differences that were highlighted. And really the purpose of this was to identify areas where clinicians and thought leaders' attitudes regarding the use of anti-angiogenic agents in elderly patients either were in alignment or did not necessarily align, creating an opportunity for education. This slide shows the members of the think tank expert panelists. So let's begin with a brief summary of the history of the treatment of advanced non-small cell lung cancer in the elderly. I think this goes way back to the ELVIS trial. ELVIS stands for Elderly Lung Vinorelbine Italian Study, and this was really the first age-specific trial defining the elderly as patients 70 years or older. In this phase 3 trial design, patients were randomized to either best supportive care versus the same best supportive care plus vinorelbine as a single agent. 191 patients were randomized with advanced stage disease. The vinorelbine was given on a day 1 and 8 every 3-week schedule for up to 6 cycles. You see in the table at the bottom of this slide that the median age was 74 years of age. However, patients up to the mid-80s were treated. These were predominantly male patients, predominantly stage 4, and predominantly good performance status. However, it's important to note that a quarter of the patients in both arms were performance status of 2. This slide shows the Kaplan-Meier survival curves in this phase 3 trial showing a significant benefit with regard to overall survival in favor of active treatment with the single agent vinorelbine versus best supportive care. So this ushered in an era where elderly patients were now considered treatable. They were offered treatment as a course of therapy. Now, one of the next questions addressed is shown on this slide, the MILES trial. This was building on the ELVIS trial and compared a second single agent gemcitabine versus the combination of vinorelbine and gemcitabine. So a single agent versus combination trial. You can see from these survival curves that the conclusion from this trial is that either vinorelbine or gemcitabine performed similarly, in that there was no survival advantage for the combination of vinorelbine and gemcitabine in patients over the age of 70. So both the ELVIS and MILES trial kind of solidified single agent chemotherapy as a standard of care in the elderly population. That changed when this trial was reported and published in The Lancet. This was the IFCT 0501 trial, a multi-center phase 3 randomized trial. Patients were recruited to this trial who were aged 70 to 89 years with an advanced metastatic non-small cell, performance status of 0 to 2. The control arm of this trial was really built off the MILES trial. Physicians could use either single-agent vinorelbine or single-agent gemcitabine monotherapy, and the investigational arm was a combination of carboplatin plus weekly paclitaxel, as shown on the slide. 451 patients were enrolled and randomized. The median age was 77 years, and the median follow-up was about 2.5 years. There was a significant impact on overall survival for the doublet chemotherapy with a median overall survival of 10.3 months versus 6.2 months for monotherapy. This had a hazard ratio of 0.64 and a p-value of 0.0001. Similarly, 1-year survival was increased by nearly 20%, 44.5% on the combination arm versus 25.4% on the monotherapy arm. As expected, toxic effects were more frequent in the doublet chemotherapy arm than in the monotherapy, most commonly neutrophil count decreases as well as asthenia. So this trial really ushered in the use of doublet chemotherapy in the older population as a standard of care. Now, what about the role of VEGF inhibitors in advanced non-small cell lung cancer? Well, this slide summarizes just a brief initial eligibility checklist for those patients who are either eligible or not eligible to receive bevacizumab. Bevacizumab was the first anti-angiogenic agent. It's a monoclonal antibody directed at isoforms of the VEGF ligand. You can see in the first bullet there are a list of things from the initial experience with bevacizumab in non-small cell lung cancer with regard to ineligibility criteria. Squamous histology, brain metastases, or ongoing coagulation were not part of the original trial that defined this as the standard of care. The presence of hemoptysis or poor performance status were also excluded. The major eligibility criteria for bevacizumab remained non-squamous histology. Subsequently, we have shown that it is safe in selected patients to use bevacizumab in patients with treated and controlled brain metastases, as well as those patients who are receiving ongoing anticoagulation. ECOG 4599 was the pivotal trial comparing paclitaxel carboplatin alone versus the same doublet combination plus bevacizumab. And the bevacizumab was given with each day of chemotherapy and then continued after chemotherapy stopped after 6 cycles as maintenance therapy in all intents and purpose. However, at that point, it was called treatment till disease progression. You can see in the eligibility box that it was a histology criteria, non-squamous, non-small cell, no history of hemoptysis, no brain metastases were allowed on this trial. And as I mentioned, no patients receiving therapeutic anticoagulation were allowed. You can see in the box in the bottom part of the slide that there was a significant improvement in overall survival, whether one looks at the median survival, 12.3 months for the bevacizumab arm versus 10.3 months on the control arm, and then about a 7 to 8% difference in the 1 and 2 year overall survival benefit is shown here. This was statistically significant as well as clinically relevant to those of us in practice. Additionally, there was more than doubling of the response rate from 15% on carboplatin paclitaxel alone to 35% on the bevacizumab arm, and a significant benefit in patients with regard to progression-free survival, as shown in the table. Now, there was subsequently an elderly analysis of ECOG 4599. 224 of the patients enrolled on ECOG 4599 were 70 years of age or older. Remember, this was not a stratification variable, nor was it a pre-planned analysis. In this subset, there was no improvement in overall survival or progression-free survival. And as shown in the table, there was more grade 3 to 4 toxicity in the elderly patients on the bevacizumab arm. You can see in those patients over the age of 70, more neutropenia, more GI bleeding, more muscle weakness, neuropathy, and a doubling of the treatment-related deaths noted on those patients over the age of 70 receiving bevacizumab. So this led to some concern about the use of anti-angiogenic agents in the elderly population. This slide shows the progression-free survival. As I mentioned previously, not statistically significant. And then again, the overall survival shown in this slide, not statistically significant. Now, in the ARES registry, elderly patients were analyzed. The ARES study was really an observational cohort. It was initiated in 2006, and the purpose of it was really to look at the outcomes associated with bevacizumab use in a less selected real-world patient population. There were nearly 2,000 patients who received first-line treatment with bevacizumab plus chemotherapy. And as shown in the last bullet, the study enrolled over 1,000 patients aged 65 years or older and 370 patients aged greater than 75 years or older. And as you can see here in the ARES cohort, that with regard to overall survival, as shown in the bottom, or progression-free survival, that at least from progression-free survival, looking at 75 years as a cut point, there was no difference in PFS. As expected, in the overall survival curve on the bottom, patients over the age of 75 had a lesser survival rate, but still pretty good when you look at younger patients, 13.5 months versus 11.6 months for those patients over the age of 75. Now, Point Break was also an interesting trial. This trial was a phase 3 superiority trial attempting to show the superiority of replacing paclitaxel with pemetrexed in the ECOG 4599 regimen. In this case, patients with stable treated brain metastases were allowed. This was a good performance status population, ECOG PS 0 to 1. Patients were randomized to the control arm shown on the bottom. This was essentially the ECOG 4599 regimen, paclitaxel, carboplatin, bevacizumab, in this case for 4 cycles, and then continued with bevacizumab monotherapy as maintenance. The investigational arm was the substitution of pemetrexed for paclitaxel in the induction phase, as well as the continuation of pemetrexed plus bevacizumab in the maintenance phase. Again, I mentioned this was a superiority trial. Now, this slide just shows the baseline characteristics of the patients based on age, first cut by less than 70 versus greater than 70, but also highlighting the slightly more than 100 patients who were over the age of 75. And you can see the patient characteristics were similar in all of these subgroups shown on this table. Now, this is the top-line data from Point Break. As I mentioned, this was essentially a negative trial. The pemetrexed arm was not different than the paclitaxel arm of this trial. You see the hazard ratio for overall survival is 1.0. This was the primary endpoint of the trial, and the 1 and 2 year survival rates were identical. To the left, there was a slight numeric advantage which did achieve statistical significance for progression-free survival, as shown here, but most of that is on the righter half of the curve, if you will. And again, I will note there was no difference in overall response rate, 34% for the pemetrexed arm and 33% for the paclitaxel arm. Now, an age-specific analysis was done looking at the overall survival in the intent-to-treat population for the age groups as previously mentioned, cutting the data at 70 years of age as well as 75. And the point of this slide is to show that with regard to the 2 arms of the trial, either pemetrexed or paclitaxel, that there was really no significant differences. You see the p-values under the hazard ratios. None of them show anything close to significance. And so these regimens in all of the age groups performed similarly. This was also true of PFS, with the slight exception of the pemetrexed carboplatin in the younger patients. But this really mirrored the data that I showed in the intent-to-treat population. So very similar and no surprises on this particular slide. What's interesting to note is an analysis of the grade 3-4 toxicities. And this, again, is cut by 70 as well as greater than 75 years of age. We would expect that there would be a slight increase in toxicity in the elderly population because of the decreasing level of reserve of end organ function, and you see that's true. Anemia slightly greater in the older population with paclitaxel, very similar with pemetrexed. Thrombocytopenia very similar. Febrile neutropenia, again, we would expect it to be higher in the higher age groups, and we do see that effect here with the paclitaxel arm. Neuropathy, very similar findings. So I think this suggests, again, that one must pay attention to age, but age in and of itself is not necessarily a contraindication to the use of these regimens in this setting. So the conclusions from Point Break was that the primary endpoint, as I mentioned, of overall survival was not met. There were really no significant differences observed in overall survival between arms for age subgroups. The secondary endpoint of median PFS favored the pemetrexed arm with a hazard ratio of 0.83, but numerically a very insignificant difference of less than 0.5 months in terms of a numeric difference. The progression-free survival, again, in the younger subgroups was better. This went along with the intent to treat population. Both regimens showed tolerability, although, as I pointed out, there were minor differences in some of the grade 3 or 4 toxicity endpoints. And I think that this is an important analysis from Point Break summarizing this data in the elderly. Now, this slide looks at results of overall survival and progression-free survival in a pooled analysis of Point Break as well as ECOG 4599. And in the upper half, we show the overall survival on patients treated with the combination of paclitaxel plus carbo plus bev versus the doublet alone. And this included both ECOG 4599 as well as the Point Break patients that I previously mentioned. And you see here that in overall survival, in both of these studies, you see that in patients less than the age of 75, that this favored the use of bevacizumab. The number of patients over the age of 75 were relatively small. The confidence intervals are very wide, but it brings into question in that population of patients how we should view the role of bevacizumab. And this was also similar for progression-free survival, as shown in the lower half in those forest plots shown for progression-free survival. Here are the overall Kaplan-Meier curves for survival. Looking at the top half, figure A, less than 75 years. And you see here, if you look at the addition of bevacizumab, you see a hazard ratio of 0.76 and a significant p-value, and those curves clearly look different, whereas if you look at the older patients, those curves seem to be mostly overlapping. The hazard ratio is 1.1, and the log rank p-value is not statistically significant. So again, one must be careful about those patients over the age of 75 in the use of bevacizumab. Particularly when you look at the incidence of grade 3 to 5 adverse events with the addition of bevacizumab, the rate does increase with the use of bevacizumab, whether you're less than or greater than 75 years of age. In those patients over the age of 75, you see an 8% grade 5 toxicity rate versus 2% for paclitaxel carboplatin. And then rates of discontinuation shown in the older patients, 29% versus 17% in the younger patients using 75 years as the cut point. You do see some difference in paclitaxel carboplatin also based on age, but much more pronounced in the bevacizumab cohorts here with regard to discontinuation of treatment simply due to adverse events. So this exploratory pooled analysis of the ECOG 4599 and Point Break studies demonstrates a statistically significant and clinically meaningful overall survival in PFS benefit for the patients less than 75 years of age, but not so for those patients over the age of 75. And I pointed out the concern about the incidence of grade 5 events. One caveat, obviously, is that this is a rather small group outside of a clinical trial. Clinicians must use careful judgment when administering bevacizumab to patients 75 years of older because of the concerns of an unclear impact on overall survival as well as the risk of increased toxicity in that population. Now, this is an interesting analysis looking at the SEER database update. Again, this was looking at patients who received bevacizumab in combination with carboplatin paclitaxel. It's divided up by age, 65 to 74 years, and then 75 years of age or older. one can see that in both groups, whether it's the younger or older population, the red curves, which are the doublet carboplatin paclitaxel, are not quite as robust as the blue curves, which is the use of bevacizumab in the older population. And you can see that in this analysis, there was really little difference between those patients receiving bevacizumab age 75 years compared to their younger counterparts, 65 to 74 years. Now, this is not randomized data. One needs to be very careful about this, but it suggests that, again, patients over the age of 75 can be candidates and can receive this drug with acceptable toxicity. Now, again, as this slide shows, caveats of the SEER database analysis, it is retrospective, it is not randomized and therefore uncontrolled. There are a number of confounding variables. There's obviously a reason why patients either over the age of 75 either received bevacizumab or did not receive bevacizumab. So one needs to be aware of that, and it really highlights the issue of those decisions we make with regard to patient selection for various therapies. Well, what about second-line options for the elderly population? We do have a recent indication a couple of years ago of the use of ramucirumab in combination with docetaxel based on the REVEL trial here. This, again, was a trial that involved stage 4 advanced non-small cell lung cancer patients who had received one prior platinum-based chemotherapy with or without maintenance. It did allow prior bevacizumab. Interestingly, with this agent, now ramucirumab is an antibody to the VEGF2 receptor. Again, different mechanism of action than bevacizumab, which is an antibody to the VEGF ligand. This trial did include all histology, specifically did not exclude squamous histology patients. The trial was limited to performance status 0 to 1. You see the stratification factors. The randomization was to a control arm of docetaxel, 75 milligrams per meter squared, versus the same dose of docetaxel with ramucirumab given at 10 milligrams per kilogram. The primary endpoint was overall survival, and the secondary endpoints are shown on this slide here. Treatment was allowed until disease progression or unacceptable toxicity. This was a positive trial in favor of the ramucirumab arm. This slide shows the progression-free survival in the intent to treat population, about a 50% increase in median PFS. Hazard ratio was 0.76 and a p-value of 0.0001. The overall survival, again, was similarly affected. There were about a 1.4 difference in median survival, shown here 10.5 months for ramucirumab plus docetaxel versus 9.1 months for the docetaxel single agent arm, the control arm. You see the survival curves here are separate. The hazard ratio is 0.857 and a p-value of 0.02. Here are the selected adverse events of special interest shown here. And we can see that most of the differences on the arm were really related to grade 1 or 2 toxicities as these relate to epistaxis, as shown here. Otherwise, both of these regimens appeared to be relatively safe. There has not been to date an age-specific analysis of this trial, but there was no sense from this trial that the elderly patients really performed any differently in this setting. So again, in terms of the REVEL trial, it met its primary endpoint of overall survival improvement. Also, there were improvements in PFS, as I mentioned. I did not show the overall response information, but the response rate was nearly doubled with the addition of ramucirumab. The overall survival and PFS improvements were consistent in both squamous and non-squamous. There was no increase in significant adverse events leading to death on the ramucirumab arm, and the safety profile is pretty much what we would expect for an agent in this class combined with docetaxel. And really, this trial is remarkable in that it was the first study showing that the addition of a novel agent to standard chemotherapy is a mechanism to improve survival in the advanced stage disease. We have another trial in this setting referred to as the ULTIMATE. Here's the study design. Again, this was in patients who had prior therapy, advanced disease. PS2 patients were allowed in this trial. Docetaxel was the control arm. And in this case, paclitaxel on a weekly basis in combination with bevacizumab given every 2 weeks at 10 milligrams per kilogram was the investigational arm, and this treatment was continued until either progressive disease or undue toxicity. The primary endpoint was progression-free survival, and you see there was a significant advantage in favor of the weekly paclitaxel plus bevacizumab arm here with a hazard ratio of 0.62 and a p-value of 0.006. The trial is an interesting one. There was also an objective response rate benefit, and I showed you the progression-free survival benefit with a 38% risk reduction in progression. There was less hematologic toxicity than docetaxel, as one would expect. We know that giving taxanes on a weekly versus Q3 week basis does result in less hematologic toxicity. And the authors concluded that this trial introduced the possibility of weekly paclitaxel with bevacizumab as a treatment option in the second or third line treatment for patients with non-squamous non-small cell lung cancer. So getting to the bottom line here, I think this data in the elderly population supports the contention that certainly bevacizumab is not contraindicated in the elderly with advanced non-small cell lung cancer. These analyses, including the recent SEER database analyses, suggest that patients may benefit up to and greater than the age of 75. As is vitally important in all of these decision making, one needs to use good clinical judgment in terms of offering anti-angiogenic therapy to those patients in the older age groups, being aware of the incidence of toxicities are going to be higher in this population, so one must be selective, and also be selective when you deviate from the standard regimens that these agents were typically studied with, as I reviewed in this presentation. So I want to thank you all for joining us today for this clinical debate and consensus recommendations on the use of anti-angiogenic agents in lung cancer, focusing on the elderly patient. I hope this is educational to you, and I hope this helps you manage that elderly patient population with advanced non-small cell lung cancer.